So I work at the National Cancer Institute. I'm in the HIV and AIDS one. Would it be better if I stood up there? Probably, yes.
Yeah, no.
So you're in the side.
You.
Yeah, I can sit right over here. So you're not turning your head. So I work in the HIV and AIDS malignancy branch, and I work with patients who have HHV-associated Castleman disease. And HHV stands for human herpes virus 8. I often call it KSHV or Kaposi sarcoma herpes virus. So if I slip up and I say KSHV, it's the same thing as HHV. Okay. So I know that
Maybe if you point it here.
Yeah,
here we go.
technology.
Should I just sit at the computer or am I too far away?
Yeah, we might need to do that. I thought there was some batteries that they left somewhere, but I don't know where they are right at the moment.
I have my. You may have to just. You may have to just touch the screen itself in order for that to work.
I might have to touch the screen itself.
No, just
Advance
just advance it, and then you should be able to advance it.
Oh, thank you.
Nice. Smart man, smart man.
Excellent.
I was in IT for 25 years.
Ah, I clearly was not. All right. So I know that Dr. Fagenbaum talked a lot about the different types of Castleman disease this morning, but I just want to sort of make sure we understand exactly what HHV positive MCD is. Or MCD stands for multicentric Castleman disease. Okay, so this is not a cancer. It is a lymphoproliferative disorder of B cells. So that means that there is no one cell that gets mutated, like in cancer, that then grows out as a clonal disease. So this is not a cancer, a lymphoproliferation, so extra growing cells. These cells are growing abnormally.
Can I get a copy of this one?
Absolutely.
Awesome. Thank you.
So it's caused by the virus, human herpes virus 8, and it is most common in people living with HIV. There are people who don't have HIV who get Castleman, but that is even rarer. The only requirement, though, is that you have to have infection with HHV-8. So technically, anyone who is infected with HHV-8 could be at risk for this disease. And it's important to remember that HHV causes several other diseases. So Kaposi sarcoma, that's this tumor right here on the skin. And then also 2 different types of lymphoma. So those are types of cancer. The first is called primary effusion lymphoma, and the other one is HHV large cell lymphoma. It's not important that you remember the names, but it is important that you know, and your doctor knows, that when you're diagnosed with Castleman, they should actually be looking for and thinking about, do you have these other types of tumors?
And how similar are like the symptomatology between these 3 different things caused by
It's a
HHV?
really good question. So Kaposi sarcoma is very different.
Okay.
Kaposi sarcoma usually comes about as tumors on the skin. It can also cause tumors in the lungs and the GI tract. So you could have breathing problems or GI problems like diarrhea, bleeding. But the rash, these sort of violaceous plaques on the skin, are what is most commonly seen. And I would say about 30 to 50% of people who have Castleman disease also have Kaposi sarcoma.
Okay.
So it's fairly common if you have this type of Castleman disease to also have Kaposi sarcoma. These lymphomas actually have very similar symptoms, pretty much exactly the same as Castleman disease.
Oh, wow.
So your doctor, when they're trying to diagnose you with Castleman disease, because they're suspecting that, they need to also be thinking, could this be lymphoma? Okay.
Also, are those plaques like painful or?
No, they're not painful. They're just sort of, they can be raised. I'll show you another photograph of another person who has Kaposi sarcoma, but they can be they can be very painful and disfiguring because they can cause a lot of swelling in the legs.
Okay.
Or like if they're on your feet, they can be very painful. They can get infected. And Kaposi sarcoma can go into the lymph nodes as well. So causing some backup of lymph fluid and causing some swelling, often in the lower extremities of the legs. But like just on the back, they're not painful, but it is really stigmatizing for a lot of patients because particularly, gay men who lived through the beginning parts of the HIV epidemic when Kaposi sarcoma was the most common tumor, and they were often on the face, and like people were easily identified as having HIV. There's a lot of just sort of, it's very stigmatizing in general. So it's even when this is sort of minor Kaposi sarcoma, we often treat it very aggressively just because it's uncomfortable for patients.
Okay, thank you.
So these are two of my patients with Castleman disease. So the symptoms are pretty similar to idiopathic Castleman's disease in some ways. So there's lots of fevers and night sweats. Patients can have weight loss. I also caveat that with there can be weight gain because people can gain a lot of fluid. And so like that's my patient there who has a big belly full of fluid caused by Castleman disease. There can be rashes, and these are rashes separate from Kaposi sarcoma. So just very odd sort of allergic type reactions that can kind of come and go.
Can you talk about the swelling? When I had Castleman's, I had the large stomach, but I also had fluid around my heart. And my legs were huge.
Yep.
So it's not just the stomach, it's the entire body.
No, you're exactly right, Kent. So it can really be anywhere. And that's the reason why you get a lot of swelling is because you're inside your blood vessels. One of the things that's really important to keep that fluid inside the blood vessels is the protein in your body. And one of the proteins in your body called albumin, when you have a lot of inflammation going on, the albumin drops really low. And that allows that fluid to leak out. So you're exactly right. It can leak out into around the lungs, around the heart, really anywhere in the body. Absolutely. Good point. You have enlarged lymph nodes, a big spleen and a big liver, and those can cause like pain, difficulty eating.
Very much so.
So, and oftentimes the enlarged lymph nodes will be in the neck or under the arms. Those are the most common places. But really, Castleman's disease can make people feel many different ways. People are just sort of like, I feel really tired, or something's not right with my breathing, even if they don't have fluid around the lungs. Something's not right with how I feel when I eat, or it can be very vague and nondescript. And then I mentioned Kaposi sarcoma. So you can see my patient here with this Kaposi sarcoma on his legs, causing a lot of edema. He actually had to have like a lot of wound care to his foot. So it can be really disfiguring. The other thing about it is that sometimes people have had Kaposi sarcoma in the past. It's been treated. The HIV is well controlled. And all of a sudden their Kaposi sarcoma comes back. And we've seen that when people develop Castleman disease, that suddenly Kaposi sarcoma kind of shows up. And it can be very distressing for patients because they're like, I'm doing everything right, what's going on? And it may be something, doctors need to think about, oh, could this actually be something else driving the Kaposi sarcoma? So we talked about some of the abnormal lab tests a little bit already, like the albumin I mentioned, that can go low. But the blood counts often can go very low. And so the more severe the Castleman's is, the more different types of blood cells that'll be affected, and the lower that they will be. So we see patients a lot who have low platelets, a lot of anemia, even some white blood cells being low. The sodium will go low, which also can contribute to a lot of the swelling because sodium is very important for actually the fluid shifting in our body.
Sorry, just to interrupt. In terms of the abnormal blood counts, is that really just in terms of the hemoglobin and things like that, or is it other markers that are indicated?
Good question, Kent. So the hemoglobin is one. The platelets are really important too. I think that's the most common one I see low. And then, our normal hemoglobin is like 12 to 15. When patients have Castleman disease and their hemoglobin's low, it's often like 5.
Wow.
It's like really low. And I'll talk a little about this later. Sort of knowing how your Castleman's presents, like I know I had really low hemoglobin when I had Castleman disease. That's something that to watch going forward, because that's likely what could happen again if the Castleman disease came back.
Question about the platelets. I enter like cases for the registry, and I see some IMCD patients that have thrombocytosis, like high platelets.
Mhm.
For HHV-8 positive, is it always just low platelets, or do you see thrombocytosis as well?
So it's a really good question. So the oftentimes when people have low hemoglobin, there's different reasons to have low hemoglobin in different types of Castleman disease. If someone has iron deficiency, and that's because they've had bleeding or something like that, and that's why their hemoglobin goes low, the platelets often will go high.
Okay.
So sometimes when people have low hemoglobin, seeing a very high platelet count can be indicative that that's sort of the iron deficiency could be driving that.
Okay.
The blood counts can do what the blood counts want to do.
Okay.
And no patient has the same, things happening. There's a lot of symptoms listed here. There's ones I've seen that I haven't mentioned. These are sort of the most common ones. You don't have to have all of these, but it's sort of a constellation of symptoms that you could have.
Okay.
So again, this is a B cell proliferating disease, and these B cells are giving off chemicals in the body that are inflammatory. So all these symptoms are coming from the fact that these B cells infected with HHV-8 are giving off inflammatory signals. And so some of these inflammatory signals that we can follow are the CRP, ESR, and sometimes people will follow people's cytokines. Just like in idiopathic Castleman disease, interleukin 6 is very high in people who have an active MCD flare. And then also, you can check the level of the HHV virus in the blood, and that will be very, very high in people who have HHV-associated Castleman's. If the HHV level is 0, it's not Castleman's disease due to HHV-8. Just pretty much rules it out.
So I know there's like LANO-1 stains for like lymph nodes for HHV. Is it possible to have a lymph node that does stain positively for LANO-1, but then not have HHV in your blood?
Yes.
Okay.
So the LANA just stains for HHV infection. So if you have Kaposi sarcoma in your lymph node, the Kaposi sarcoma stains for HHV, the LANA stain. And you usually do not have that in the blood.
Okay.
You just have Kaposi sarcoma. Sometimes when you have the lymphomas associated with HHV, they don't always all have it in the blood either. But if you have active flaring HHV Castleman disease, you should see it in the blood. And if you don't, it's not what it is.
Okay.
Okay. So you may recognize pictures like this if you had a big spleen. So, so it's very hard to diagnose, like all forms of Castleman disease. And one of the things that makes it very difficult is that the symptoms are wide ranging, different among different people, and also they can come and go. So you can have a flare, Castleman, and it can go away on its own without having actually done anything. It's likely to just come back, but people can have these sort of intermittent flares with symptoms in the lab overnight come up, and then they go back down. So the reason why this is hard for a lot of physicians to diagnose is because you have a patient who might have HIV and they look like they have sepsis. And common things being common, people with HIV can have increased infections. And so someone comes to the hospital really sick, they look like they have an infection, you treat them for antibiotics, you never find an infection, but you're like, oh, it must have been an infection, they got better, because that's the natural history of Castleman. And so it can be very difficult to diagnose. And currently the way you have to diagnose it is by taking out a lymph node or a piece of a lymph node. And even when you do that, there's many pathologists who don't know how to read biology, don't know how to, diagnose Castleman from a lymph node, which is why it's really important, I think, to, even if you don't see a doctor at a specialized center, to have your lymph nodes read at a specialized center. And this is very common for people to do, to send it to, where I work at the NCI, our pathologist, Elaine Jaffe, wrote the book on HHV Castleman disease and how to diagnose it. So I think that can be very helpful.
Yeah, the other thing is just in terms of when I got diagnosed, not a lot of doctors know about Castleman's. And even after I was diagnosed and still going through some of the symptoms and going through to emerge, they would have to read up on it. You tell them if Castleman's, so what's that? You have to read up on it, right? So
It is a rare disease. I mean, I see patients with Castleman every single week, but that's not the norm. And so it is unusual for physicians to have experience with. So you have to get a lymph node biopsy currently. And your doctor should be asking about your symptoms, checking those labs that I mentioned, and then they should really be getting scans. So on the left there, that's a CT scan. That's like if I was cut in half this way and you're looking at me. And that's a really, really big spleen and liver, like really big on my patients. And then, I mentioned that oftentimes the lymph nodes are in the underarms and the neck. So this is a PET scan. So things that are really, really active, like Castleman lymph nodes, are bright. So these are lymph nodes here, lymph nodes here, lymph nodes here. This is the heart that's actually normal. It's very active, so it's always bright.
That's a good thing.
This person's spleen right here, you can see, is also bright. These are the kidneys. That's how the dye drains. So those are also always bright, and the bladder. So the abnormal stuff about this scan is all this stuff here. Yeah. Both those patients did really well. We're fine.
what would you expect to see just with a normal patient? Not those white areas.
Yeah, so there would be nothing bright here at all.
Other than the heart.
Only thing that would be bright would be the heart, the two kidneys here, and the bladder.
Okay.
Yep. And here, so this is the liver here. It should probably be about that size. And this is the spleen, and it should probably be about this. I mean, you can compare, these aren't the same scale, but you can kind of see how much of the abdomen, this is the liver here and the spleen here, take up on this person compared to this person. Yeah. These are the lungs here out in black. Air is always black on a scan. You can see those lungs are really tiny. They're like up here because somebody's got such a big spleen and liver. Yeah.
You said they're doing fine, this patient, or both of these?
Both
patients?
these patients have been treated and are like totally fine. That's not the way the
Great.
CT scan looks anymore. Yeah.
All like the IMCD patients I enter with splenomegaly, they complain of abdominal pain. Is it due to splenomegaly?
Yep. There could be other reasons. There could be lymph nodes, but it's splenomegaly like this is very uncomfortable.
Okay.
Your diaphragm, what helps you breathe, the muscle that helps you breathe up and down, is very sensitive to things like pushing on it and irritating it. So if you have like a big liver spleen. Okay, so luckily there's excellent treatment. Rituximab is a monoclonal antibody that targets B cells. Did you have rituximab? Excellent. So it's really effective. I think probably more than 95% of patients have a remission of their Castleman disease when they get rituximab. And the other, patients who don't, it was probably they were really, really sick and people recognized too late what was going on. So it's really effective. And then most people will not have a flare again after they are treated with rituximab. But I would say about 10 to 15% of my patients do have subsequent flares, and you can use rituximab again very successfully. I have really never used rituximab in someone who I thought the only thing that was going on was Castleman disease without a remission. And the patients where it doesn't work, I think I'm missing lymphoma usually.
When I had rituximab,
Yeah.
it was like after the third or fourth treatment, it was like the light switch just turned on. It just like it was one day, just I lost all my fluid, and was so much better.
It's remarkable.
It was just like, it wasn't just a slow progress. It was just like overnight. It was like
Yeah,
done.
I'm so glad.
Yeah,
It's just getting to the diagnosis
exactly.
that makes it very
That's the
difficult.
longest part.
How long did it take from like the symptom onset to like actually get that diagnosis written?
I actually got, when I had symptoms for several months,
Okay.
but I just ignored it because I just thought I was just working too hard. I was working long hours.
Okay.
And it was on Father's Day when I actually went into the hospital. My wife is in healthcare, and she goes, "I think you have congestive heart failure," because I was sleeping like, all the time.
Okay.
And, they diagnosed me actually with lymphoma.
Mm.
And then when they got the results back from that it wasn't cancer, they were like lost. They didn't know what to do. So it wasn't until an oncologist who finally said, "You know what, I'm taking over your case. I think I know what it is."
Okay.
And it was then that we found out with doing lymph nodes.
That's great. People who have HIV should also be on antiretroviral therapy. There's no one who has HIV who shouldn't be on antiretroviral therapy, but you don't stop antiretroviral therapy. You give rituximab. You don't stop it when people are sick. It just always is there. Okay, so I mentioned rituximab, and you mentioned your third of 4 doses. So it's given IV 4 times 1 week apart. It works really well. The other, so remember I mentioned that Kaposi sarcoma is pretty common. The problem with rituximab is that it makes KS much worse. It's because you deplete the B cells, you immunosuppress
Right.
someone even more, and so their Kaposi sarcoma often just gets much worse. So what we do is we give a very low dose chemotherapy. The good thing about Kaposi sarcoma is that it doesn't take much to treat it. And we use a medication called Doxil. At the dose that we give, there's almost 0 side effects. Most patients have no idea they're on Doxil. And they're also feeling much better from their Castleman disease. So they're like, whatever. So we give that in conjunction with rituximab to prevent the Kaposi sarcoma from getting worse and to treat it. Okay.
So is that like retux every week and the Doxil every 3 weeks, or is it retux plus the Doxil?
So the way it was originally studied, it was actually studied at our center and developed at our center. They gave it every 3 weeks. The way we give it now, I've been giving it this way for the past 5 years, is I give the rituximab once a week to get patients in their Castleman feeling much better. Don't wait 3 weeks. So give that every week, but then give the Doxil every 3 weeks.
Okay.
Yeah. And Kaposi sarcoma treatment is much more difficult than Castleman treatment. You have to continue it for quite some time often. Luckily, the drug is really well tolerated and there's other medications we can use now too. The main thing is you have to get someone through a Castleman's flare and then you're like, okay, now we'll deal with the Kaposi sarcoma. Okay. Probably know, Kent. The major side effects of rituximab are infusion reactions. So while it's actually going into your vein, and so you can get fevers, chills, low blood pressure, hives. Rituximab is one of the most common medications given in an oncology center. So people are very astute. No matter whether they know anything about Castleman or not, they know about rituximab. So it's very easy to manage these reactions. You slow down infusions, stop infusions a little periodically, and it's really well tolerated. It does cause low antibody levels, which has significant, I think, implications for the COVID-19 pandemic. But usually, your B cells are the ones that make antibodies. Those will come back within a few months. It can cause a flare of hepatitis B or hepatitis C when you give rituximab, so you need to check for it beforehand. Most people who have HIV are on medications already that actually treat hepatitis in their antiretroviral therapy, so you often don't have to change a lot of things. But it's important if someone is not on anything for their HIV to make sure that they start something to suppress the hepatitis before you give rituximab.
Is there like a certain amount of times you can receive rituximab in your lifetime, or you can just get it
Nope.
like?
Nope.
Okay, wow.
Nope, good question, no. Yeah, there's certain chemotherapy drugs that we think that there's a limit. Rituximab is an antibody, it's an immunoglobulin, and it's pretty safe. I think I've given it to one patient now. The most I've given was like 5 different flares he's had now, maybe. So, and we give it every time it gets better.
Okay.
In your B cells are, antibodies are important, but in the scope of sort of all of your immune cells, it's fairly well tolerated, and the infection risks it's not like if you don't have T cells or you don't have neutrophils and
Okay.
certain other types of white blood cells. Yeah. And I mentioned so liposomal doxorubicin is Doxil. That's the one for the Kaposi sarcoma. It can cause some low blood counts and some cracking of the skin on the hands and feet, usually at much higher doses that you'd give for other types of cancer, and not with what we give. Okay, I know that Dr. Casper is gonna talk about this, but I think specifically just people who receive rituximab should be getting this medication Evusheld. It's being vastly underutilized by clinicians. It's 2 antibodies that can prevent COVID. So you don't give it to people who have active COVID or who had a recent exposure. And we often give this to patients just before they get their rituximab. You can give it every 6 months. The other thing that I really should include. Go ahead, yeah.
This is new. So I'm in remission. This is not something that I would need to be considering, or.
So how long ago did you receive? Do you feel comfortable talking about? Okay, 4 years ago? Yes, so you would be fine. You should get your regular boosters. So every 6 months, generally a booster. The new bivalent booster is available now, and you should get that if you have not had another booster within the last, if you've not had COVID within the last 2 weeks, you can get that booster. So that's the new booster should be available.
That's the mRNA.
Yeah, it's another mRNA vaccine.
Mhm.
So Moderna and Pfizer
Mhm.
are both mRNA vaccines, and they both have now come out with a new vaccine called a bivalent.
Okay, my wife was talking about that,
Yeah,
and it's not going to be available till probably December time.
it's available now. It should
In
be.
Canada, it's not.
Oh, in
available.
Canada, I apologize.
Yeah, that's a
Sorry.
good point.
Good point. Okay. So maybe while you're here, I don't know. So yes, so whenever that's available, the Evusheld is not something I think that you need.
Okay.
People who have HIV, we've generally been giving it, but in general, people who just had rituximab 4 years ago wouldn't need that. I should have put a slide about, was there anything else about that?
No, that's correct. Yes.
Okay. I should have put in a slide about monkeypox because we are seeing a lot of monkeypox. I've had a couple cases now and patients actively receiving cancer therapy who have HIV. So anyone who has HIV or who is a man who has sex with men or has had contact with someone who's had monkeypox, close contact or sexual contact, should be getting the monkeypox vaccine. It's the vaccine that's approved for smallpox. It's safe. It can be given in people who are immunocompromised. And so that should be given because it really complicates therapy when it happens. There's also a medication called TPOXX to treat monkeypox that you can get from the CDC if someone develops monkeypox.
Can you explain real quick what bivalent signifies? Like, what does it mean?
Yeah, good question. Sorry, I didn't explain that. So the original COVID strain, that's what all of our vaccines were developed for.
Okay.
So when COVID was first discovered, we had the first genetic sequence of it. That's what they're based upon. You've probably heard there's been a lot of changes since then.
Yeah.
In particular, Omicron is significantly different and has really evaded it's evaded all the vaccines. Basically, we cannot prevent infection with COVID most of the time. anymore.
Omicron ran through our lab. It just.
Yeah, we all have.
So, and there's even new sort of subvariants of Omicron, like the BA4 and BA5, which are predominant right now and are very infectious. So this new vaccine contains both the original target, the original virus, and then also targets the Omicron variant. And so it carries both together.
So is it just specifically the Omicron variant and the new one, not like Delta or anything like that?
So Delta didn't evade the vaccines very well,
Okay.
actually. It was just a lot of people who weren't vaccinated at that time.
Oh, that makes sense. Oh, yeah, that makes sense. Okay.
So the original like Alpha strain and then Omicron are what are in
Okay.
the new bivalent.
Thank you. That makes a
That
lot of
makes
sense.
sense, yeah.
And I think it really is worth getting vaccinated against because it's been shown people who got BA5, you can get it again.
Yeah.
It's a tricky virus.
Is there expected to be cross-reactivity between the original strain and the newer ones, or are they so different from one another?
They're pretty different.
Yeah.
So, original people who had COVID before the original strain have been getting the BA5 multiple times because it's just so infectious. It's like more infectious. It's like the most infectious disease I think that people have recognized to date among humans. So being just in the same room with someone infected for a short period of time, you can get it.
I know Dr. Casper will probably talk about this later, but for HHV positive specifically, do you ever see like a patient gets COVID and then that somehow triggers an HHV flare or?
Viruses are weird. They do weird things, unpredictable things, as we've seen with COVID. People like to think that COVID is unique, but actually it's just new. Viruses have always done these weird things, cause these weird syndromes. Long COVID, there's long every virus, really. There's nothing actually that unique about COVID.
Okay.
Am I answering your question? What was your question again?
Like, could it trigger a Castleman flare?
Yeah, so I haven't seen that.
Okay.
We've seen patients come in who were flaring and on rituximab and got COVID.
Okay.
We had given them Evusheld, so it didn't prevent it, but it seemed to have helped.
Okay.
I wouldn't put it past either of these viruses to cooperate in some way. I don't have any data to prove that, but I do think when you're sort of sick or there's something that revving up your immune system, I think could be concerning.
That makes
Yeah.
sense. Thank you.
Which is why it's important to be vaccinated and to think about Evusheld. Okay. So I feel I'm like preaching to the choir. Like you have a physician, you know about your subtype, you're here today. So I think, knowing how the Castleman's presented in the first place is really important to know maybe if a subsequent flare happens. So first time I had Castleman, maybe, you had fevers and felt really, really tired and had a lot of like brain fogginess. Well, if you feel that again coming on, go to your doctor. Maybe you had a lot of like GI distress or pain in your abdomen, see your doctor about that. Again, Kaposi sarcoma is a big one. And I think a lot of patients often suffer in silence. They're like, well, I'm getting treated for Castleman's, I'm getting my rituximab, but there's a lot of symptoms that people can have that there are effective treatments for. So, I tell my patients, you should never be nauseated. We have such good treatment for nausea. Like if you're having a twinge, please tell me, we'll fix it. When you have HIV in particular, it's really important to make sure that you're getting the appropriate prophylactic antibiotics and antivirals, and that your doctor is taking that into account when treating your Castleman's as well. Pain medication, sometimes people are sort of reticent to take pain medications, particularly opioid pain medications. I always tell my patients, this is literally what they were invented for, is to treat tumor related pain. It's the most important FDA indication for these medications. This is going to be temporary because you're going to get better. We don't want you suffering. I want you to be able to move around. I want you to be able to come to your appointments. I want you to be able to eat. So all those things are really important because if you can't do those, you can't get better. Medication help you sleep. There's a lot of anxiety around having Castleman disease. People do not sleep. Give sleep medications for a temporary period of time. And then I think also it's not just about what physicians can provide. I think it's important. There's a lot of issues with nutrition if you're not able to eat or you have low protein. Talking to a nutritionist, physical therapy and occupational therapy when you have swelling can be lifesavers. I think oftentimes a lot of the swelling gets better because of our amazing lymphedema specialists rather than anything I do. And then those lab values, I think it is important over time to know what was wrong at the beginning before you were treated, how it improved afterwards, and to monitor going forward.
How often do you think we should have laboratory markers done?
So depends on how close you are to having been treated. So if I was 4 years out, once a year if you're feeling fine. Yep.
Is there like a certain lab value you expect to like downtrend or uptrend first, or is it like a patient by patient kind of thing?
Yeah, oftentimes those inflammatory markers like the CRP and the ESR, they just like plummet.
Okay.
They go way down really quickly. I've seen numbers rebound really, like platelets can rebound really quickly with rituximab. I think sometimes the symptoms that take a little bit more time because it's not how we feel. Like the labs are not how we feel.
Reinforce how you feel.
Yeah, they're an objective measure when like really the most important measure is how is your patient feeling? And so yeah, but I think the labs often correct before the patient's feelings and symptoms.
And what's like the timeline on like splenomegaly resolving? Is that
Oh, pretty
also?
fast.
Oh wow.
Yeah, like the pain should be during that 4 weeks of treatment, the spleen should be shrinking.
That's amazing.
Yeah. Like that PET scan, like the PET can go, we call that a hot PET scan, like those lymph nodes are hot, those can go cold pretty quickly by the end of treatment. They may, they're enlarged too. They may not shrink all the way down. And that is something I see some physicians be like, oh, this is very concerning because the lymph nodes haven't shrunk down to size. And I'm like, but the patient sitting in front of me and they look amazing, they feel great, their labs are fine. Like their scan really doesn't matter.
Yeah.
Because that can take the longest to actually resolve. And it's really, you've been successful if your patient feels great and they're sitting in clinic instead of the hospital.
Yeah.
Okay, so again, any labs that were sort of abnormal before treatment is what should be a really important focus going forward. Okay. You seem like you have a positive attitude. Maintain it, it's important. Okay. Diet and exercise, like while you're sick with Castleman disease, you can eat whatever you want. You can eat fried chicken and ice cream every day for every meal if you want. I don't care. Whatever you want to eat while you're sick, totally fine with me. Afterwards, I think maintaining good nutrition, particularly protein, when you're trying to recover from a lot of edema. Exercise really does fix everything. Working with physical therapy when you can, if you're sick, is really important. And then alternative therapies, I think, can be really effective for certain people. And I think I'm always for patients trying whatever they want to try, as long as they talk about it with me beforehand, because sometimes I am like, no, you cannot take that weird CMOS, and I don't know what that is, and may interact with your HIV medications. But like, and sometimes I had one patient who wanted to do acupuncture, which I'm normally like excellent, but I was like, but you are covered in Kaposi sarcoma.
Oh,
You could bleed to death. So just discuss it with your physician.
what are like some examples of alternative therapies you would recommend?
I think acupuncture, massage, meditation, journaling, support groups. A lot of like medications I tend to shy away from because they're not regulated and I don't know what's in them. I've just been burned so many times by like people causing like severe liver problems with, some medications and so that I generally try to shy away from. Even vitamins can interfere with the absorption of certain medications. So if you're taking a
Sometimes it's food.
yeah, so it really just, I think talking with your doctor, and your doctor hopefully is going to be open to hearing about alternative therapies. But I think medications are one that I tend to sort of shy, and I call them medications because they are. So I try to shy away from that because I don't know exactly what's in all of those.
Are there any vitamins in particular that you know of that cause problems with absorption of specific medications?
Yeah, so anytime you have anything that has like magnesium or like other like electrolytes,
Okay.
those can chelate the certain medications. So I'm not saying don't take your vitamins, but just tell me, oh, I'm taking a vitamin. I'm like, okay, we'll take that in the morning and take your other medications at night,
Sure.
or vice versa. Or maybe it won't be a problem with those medications you're taking, but let's just discuss it. Yeah.
Yeah, no, with me, in terms of, I also have acid reflux.
Mhm.
So my acid reflux medication, I have to take at a certain time versus my HIV medication. I can't eat grapefruit.
Yeah.
Yeah,
You can't eat that for cereal.
I miss grapefruit. I keep thinking,
I'm actually not a huge fan.
I love grapefruit.
But I think sometimes physicians are not, they can, like Western physicians can really like put off alternative therapies, and I'm very open to it. I just want to know what you're doing. I really take a big interest in my patients, so I know everything they're doing all the time. All right. And I think stress is very stressful and very anxiety provoking to have Castleman's disease. And so just, I think doing exactly what you're doing, Ken, is really important.
I think stress for me was what really triggered Castleman's for me. I was working 14-hour days.
Oh, wow.
Yeah, I just was wore out. And I think the stress and anxiety is really what triggered to
Excellent. I think some patients with Castleman's are so severely sick, like they can be in the ICU or in the hospital for a long time, and that is a very traumatizing thing. And I really encourage people to talk to somebody, like a professional, about it, because I think being in a hospital and being critically ill is one of the worst things that can happen to you. And so most of my patients are in some kind of seeing some kind of mental health provider, either a psychiatrist or like a counselor. So just a couple of updates. This is a paper from us from last year. So I think this is the largest and longest cohort that's been published so far in HHV Castleman. We have 62 patients who've been seen since 2004 at our institution. And this graph, this is a Kaplan-Meier curve. And we think about, we're looking at patients who had only Castleman disease, or who had Castleman disease and Kaposi sarcoma, or Castleman disease and lymphoma. And so this is overall 71% of our patients were alive at 10 years. And you can see over time, we've gotten better at treating patients. And so patients who have been diagnosed in the last 10 years who just have Castleman disease are almost all alive. So this is a survival curve looking over time in years. So you can see we have some people who are out over more than 20 years now from treatment. These are like very good curves showing that like people do really well who have Castleman disease and who have Castleman disease and KS. These people who have done less well are people who have lymphoma. And so really the survival having Kaposi sarcoma doesn't really affect your survival, we don't think, with Castleman disease. But being diagnosed with lymphoma, this is a very aggressive lymphoma, and that's what really affects people's survival who have this type of Castleman disease.
So it wouldn't be necessarily Castleman's, it would be more than lymphoma.
It is, yeah, you're exactly right, yeah. Because Castleman's disease is pretty easy to treat. These lymphomas are not easy to treat. Which is why when you have a patient with Castleman disease who's not doing well, something else is going on, and you have to look for that. And this is also, we've been working for a while about alternative ways to diagnose Castleman disease. And so, like you were saying, Kent, like a lot of patients have fluid around their lungs. And currently you have to do a lymph node biopsy to diagnose Castleman disease. Well, we've taken the fluid from some of our patients who had a lymph node biopsy as well. And what we saw was that we were able to identify those cells that were Castleman cells in the lymph node. We were able to identify them in the fluid. And so we think, and we've been treating patients now based upon just the fluid and finding these cells in the fluid.
How invasive is it to get that fluid versus?
Much easier than to get a lymph node oftentimes. So particularly in patients who are very ill, who are in the hospital, it's much easier to get fluid from around the lung than it is to get a lymph node biopsy. Because to get a lymph node biopsy to really diagnose Castleman, you have to get either a whole lymph node or a big chunk of the lymph node. And that often requires going to the operating room. This can be done at the bedside.
Okay.
It's called a thoracentesis. And what they do is they take a needle and they numb up an area, and then they go in between the ribs and take out the fluid that's sort of in the wrong place between the lung and the chest wall. It's called thoracentesis. And so this publication is probably going to come out before the end of the year. We're excited because we think it's an easier way to diagnose Castleman.
Is this just with MCD?
Yes.
Patients, not the other ones?
Has it been tried with the other ones yet?
We have not, because we don't see many patients with idiopathic Castleman disease. We really just see patients with, HHV-associated, yeah.
It's pretty life-changing though. It's pretty cool.
It's just really hard, particularly for patients who are really sick. It's really hard to get lymph node biopsy.
When I had a lymph node biopsy, and one of the challenges I had was my hemoglobin. I was getting blood transfusions every other day, so they were worried about going into surgery with my already low blood counts that it would impact them by doing it. So this is fantastic.
Yeah, this technically isn't a surgery; it's a procedure.
Right.
So there are risks to it, but it is much less invasive than a.
It sounds kind of painful. Is it painful?
So I've never had it done.
You said in between the ribs, right?
So it's numbed up.
Yeah.
So it's like a pressure thing?
So, I think patients do okay generally with it. I do it myself some of the time. They're usually like, oh, okay, I don't want to have that done again. But I think also there's, we do it under ultrasound. So it's like you're guiding yourself. So you're not just like blindly sticking the needle in. So I am not the patient, so I'm not going to say it's not terrible, but I've seen patients say the bone marrow biopsy is the worst.
Oh, sure, yeah,
yeah.
but that's
All right.
really rough. Yeah.
They did a bone marrow on
Yeah.
me, and when they extracted it, I thought I was going to die.
Oh, wow.
It was so painful.
Gosh.
Wow. Ken, if you don't mind me asking, where did you get which lymph node with biopsy?
In the mouth.
Okay.
And since tocilizumab came up in COVID, and I get asked about it a lot. So tocilizumab is very similar to siltuximab. So siltuximab, which is approved for idiopathic Castleman disease, it's not approved in HHV. It stops that chemical called interleukin-6 that causes a lot of inflammation. So tocilizumab also blocks that.
So just a question, just more curiosity. With only having one drug that's approved, like, there are some others that are there, like the rituximab. In Canada, it wasn't approved for my treatment, but I'm just curious in terms of what does it take to get a drug to be approved for treatments?
Yeah, so rituximab, you're right, it's not approved here in the US, even though it is the standard treatment.
Because it's not approved, at least in Canada, I don't know what the situation is here, it's not an approved drug, so the patient has to pay for the drug.
Goodness.
Which is,
Yeah, so that's a problem, very big problem. Basically, the drug company has to do all the work and bring it to the FDA, which takes time and money. So they get paid. The drug company Genentech, I believe, that makes rituximab, gets paid a lot of money for rituximab. For many other diseases, they don't have a lot of impetus to take rituximab to the FDA for Castleman disease.
with the number of patients probably too, right?
What was that?
With the number of patients. Not as
Yeah, I mean, so it takes the drug company wanting to get it approved. That's part of the problem. I'm in a little bit of a bubble because all of the care provided at NIH is free and doesn't require health insurance. And so I don't hear, though, a lot of stories about people having trouble getting rituximab in the US because it's in like all these guidelines and things for people who have insurance, and because it is sort of like a well-known standard medicine for many different types of like lymphoproliferative disorders. But again, I'm sort of in like the NIH bubble, so I don't know how bad it is out there. Questions on that?
Yep.
Okay. And so tocilizumab, we did a small study of 8 participants who had HHV-associated Castleman disease. And it really does very quickly bring down a lot of the it normalizes some people's labs. I think it normalizes some symptoms pretty quickly, but then things come right back. So it doesn't really work. It should not be used as a standard treatment for Castleman. Where we have used it and continue to use it is in patients who are very, very, very sick with what we think is Castleman disease. We give this while we're trying to figure out what the heck to do. Is this Castleman disease? Should we give rituximab? So we've often given this sort of as what we call like a bridge to the rituximab. However, I will say that rituximab is such a well-tolerated medication. I've given rituximab to patients before where I didn't have that firm diagnosis of Castleman disease because I just suspected it so much, and I was like, weird. Nobody gets super sick without getting rituximab. That's it. Just ending on the research pipeline here from the CDCN. So have you been on? You've probably been on here before. Yeah, know all their research projects. So yeah. So that was all I had. Thank you.
Thank you so much.
Thank you.
Dr.
That was
thank you.
awesome.
That's fantastic.
I'm really curious about the fluid stuff. I'm really curious about that.
I like I've entered like one HHV patient, like so many IMCD and UCD patients, like learning all about this has been really personally helpful for
Oh,
me. So I
good.
really appreciate it.
I think a lot of the symptoms are very, very similar. I mean, it's really, and the driver of it is the interleukin 6. So I will say, so if you want an interesting factoid, so HHV-8, these viruses can make their own what we call homologs of human proteins. So a protein, it makes its own protein that mimics a human protein. So HHV-8 makes a viral IL-6
Oh, wow.
that actually more potently stimulates the cascade of the IL-6 cascade. So, which is probably why tocilizumab doesn't work that well. But yeah, it's sort of interesting. So it's a little bit different
very
there
interesting.
from intercothic, but yeah.
Thank you.
Thank you. Thank you. Appreciate it.
Yeah, glad to meet you guys.
I had a question. So the viral IL-6, is that partially what they think is responsible for the overreaction of the immune system because it
Yeah.
mixes with the endogenous IL-6?
Yeah, it's causing a lot of the symptoms. And so IL-6, like human IL-6 has to bind to the IL-6 receptor on the cell and also another this other glycoprotein. So there's two things it has to bind. The viral IL-6 actually can bypass the IL-6 receptor and just bind to the co-receptor, which is why it's much more potent. It takes less of it to sort of saturate all of the IL-6 cascade, and so it's probably a big portion of the symptoms.
Have you ever had a patient who has failed rituximab and like you're sure it's not lymphoma? And if so, like what do you do in that case?
I've never had a patient where I gave them rituximab and the Castleman's disease did not go into remission.
Okay.
It might have been a less long of a remission than we wanted. Because I do have patients who sort of have these just usually low level flares. So usually like the first flare people have is the worst one.
Okay.
And then after that, they sort of have these little flares, and it's probably also because we're vigilant and watching for it. So we don't let it get out of control. But it always still goes into remission.
Okay.
Those are the patients that I worry for the development of lymphoma, however, because when you have constant B cells proliferating and growing abnormally, that's sort of what can set the stage for lymphoma to develop.
Okay.
And patients where, you know, they have Castleman's disease, they get treated, it goes into remission, I worry much less about the development of lymphoma. And we know that rituximab reduces the risk of lymphoma because it gets rid of B cells. So it kills off B cells so they don't have the chance to mutate and develop sort of clonally into lymphoma.
Thank you.
One question for you. So I know I'm just going on an annual basis with my specialist. So one of the things that they look for is obviously my hemoglobin, because that was one of the things that went down. Should they be looking at other markers when they're doing the testing? Because my doctor's not a specialist with it. She's just an oncologist. So should she be looking at other markers?
So I like to watch the CRP. So the CRP, that C-reactive protein, which is just a sort of non-specific marker of inflammation, that's one that I really like to watch. So I usually, when our patients with Castleman's disease come in for just long-term follow-up, it's a CBC, so the blood counts, and then just a regular chemistry panel, and that will include the sodium and the albumin.
Okay.
And then a CRP. Those are the
And she has those two.
The CRP is non-specific again. So if you had like a little infection somewhere, it could be elevated. If you have COVID, it can be elevated. So it doesn't mean that you have a Castleman flare, but it might mean, oh, maybe we should see you back a little bit sooner, check again sooner if it was high.
Oh, we actually still have the other talks going on till 1, so we could all go back and join a different talk, or if everyone wants a break. We have the room for another like 20 minutes, I think. But yeah, there's snacks also back in the lobby area, so if anyone wants a snack.
Thank you. Listening to that once as well. Very interesting. Thank you very much.
Oh, yeah.
Thank you.
Thank you so much, Dr.
Great.
Yeah, thank you.